So today I'm going to talk about MCA aneurysms and the rationale for clipping in the intrasaccular device era. This is a topic that has reemerged recently because of another technology development in the endovascular world, for those of you who are not subspecialists in this, and we'll get into it. But this is an argument that many of you of all generations of neurosurgery are familiar with because of the incremental technological developments that keep happening in endovascular and reemerging this discussion and somewhat of a debate, if you will. No relevant disclosures. I really want to acknowledge ahead of time Gil and David, who helped me collect some of the data that I'll present to you from our own institutional database that includes Mike's and my MCA clipping data. And of course, my cerebrovascular team, which is composed of 3 endovascular microsurgery trained neurosurgeons. Melanie Walker is our neuroendovascular surgeon, and who's a stroke neurologist by training. And then our 2 colleagues in neuroradiology, Raj Gadki and Dan Hallam. And we've been a well-honed team for a long time, and I really appreciate all the teamwork and camaraderie that everyone has brought to the table. So with apologies to my other neurosurgery faculty colleagues, MCA clipping is without the doubt the best surgery operation in neurosurgery, hands down. It's just that beautiful combination of sharp and blunt dissection, normal anatomy, the ability to showcase your technical skills, your creativity with clip reconstructions and solving problems on the fly. And it really is just an elegant, beautiful operation, which probably motivated many of us to go into neurosurgery at some point in our careers because of all the facets of technical know-how that it brings to the table. So this is just an example of clipping an unruptured MCA aneurysm in a patient with headaches and a complex aneurysm that requires some complex clip reconstruction skills, where you have to sort of readjust the clips to reconstruct the arteries properly, use multiple clips to get the entire multilobulated construct, and then prove at the end that you haven't hurt anything while excluding the aneurysm. So what is the current practice pattern? Well, it used to be sort of this, one road, very straightforward, you have an aneurysm, you clip it. But now it's really like a super highway of many different options and choices, almost to the bewildering confusion of patients and even clinicians. And it really is a bespoke kind of application of not just data, but also personal preference, personal abilities, and skill sets. So this is an older slide. It's probably about four years old. But if I look back at my MCA aneurysm experience, it's about 17% of my treated aneurysms, and about 2/3 are unruptured, 1/3 are ruptured. You can see that I have a very strong clip bias at 86%. But you do occasionally need to use other techniques like bypass and trapping, which is rare, but certainly happens, and then coil or stent coiling, and then flow diversion or stenting. But overwhelmingly still a very clip first bias in my practice. And hopefully I'll be able to justify that to you by the end of this talk. The complication rates are, and these are all aneurysms, small, large, everything in between. And so the complication rate is about 4%, with 4, the most serious of which were 4 perforator strokes and 1 large vessel stroke. There was a case of an ICH in a clip, intraoperative thrombus in a coil case, a dissection in a coil case, and no deaths. So it just kind of gives you a lay of the land of what that kind of practice exposes our patient population to in terms of risk and benefit. But this is highly biased. This is not really data that can drive guidance of how to treat aneurysms. It's just my particular selection bias and how I decided to treat these aneurysms and the resultant complications that arise from it. So what are the factors that really can guide treatment strategy? Things like patient age, health, rupture status, the angioarchitecture of the aneurysm is incredibly important. Because of the complexity of this area in terms of anatomy and technical reconstruction of the apparent vessels. Obviously, expected lifespan of the patient and outcomes data always plays a role. But really what you're looking for is the lowest complexity solution. What's the easiest and safest way to fix this particular problem in this particular patient? And it's really moving away from which method, this old argument of clip versus coil is sort of passé, as everybody knows, and it's more about when to use one tool versus another in the given circumstances and optimizing your chances for the best overall outcome. And then finally, you have to recognize that multiple solutions are available, each with their relative pros and cons. And so one doesn't mean the other is wrong, but rather just a different set of pros and cons that need to be put in context. So if I could sort of visually summarize the clipping of aneurysms versus the endovascular treatment, you can see that the man in black is a very talented and skilled endovascular interventionalist. And our trusted friend, Indiana Jones, is the tried and true clipper of aneurysms. You can see he's very talented, very capable. But sometimes simplest is best. And so if I can have you come away with any one thing after this talk, maybe that visual summary would be it. So the treatment of MCA aneurysms, what the Achilles heel is that it makes sense to have a multimodal approach. We've got all these tools in the toolbox. Let's use them all. But where do we really struggle? Again, with the microsurgical patients, no surprise, it's the older, sicker patients. Less reserved, giant aneurysms, aneurysms with calcified necks, situations where the M2 branches arising from the neck can be difficult to preserve, retraction injury from the approach, venous infarct from splitting the fissure, taking veins, and wound infection, of course. Whereas with endovascular, it's a different set of concerns. It's high rates of thromboembolic events because of the endovascular avenue. There's treatment failures, even in spite of properly performed treatments, they can fail. There are failures where you can't even technically get the job done at all because of the anatomy or the technical difficulties involved. There are recurrences, rebleeds, access, risk of antiplatelet agents, and some of the data suggests some higher rates of intraoperative rupture with endovascular treatment of MCA aneurysms. So that's led to sort of this, around the teens, sort of this clip first approach mentality for MCA aneurysms. And it's not unreasonable. I think it's far from obsolete in this particular anatomical location. Maybe not so true for, say, basilar aneurysms or even anterior communicating artery aneurysms, where the technical risks are higher with open surgery because of perforator anatomy. Clipping is still a staid and important part of the armamentarium in the treatment algorithm because it's durable. It is useful in clip reconstructing wide-necked aneurysms. There's no need for, aspirin and Plavix and dual antiplatelet therapy. It avoids what I call the endovascular gymnastics, which was more of an issue when we were using stents to try to treat these broad-based MCA aneurysms, where it's technically very challenging to get small catheters and wires through very tortuous small vessel anatomy with acute angles involved. And then the cons, of course, of the wound healing infection. We talked about sort of the Achilles heel of surgery. But what's the problem with endovascular treatment of MCA aneurysms? Well, first of all, a lot of the aneurysms are wide-necked. So you're talking about, about a third of all aneurysms are going to be considered wide-necked, making it more challenging for endovascular cure. The main issue with MCA is the bifurcating vessels, or sometimes trifurcating vessels, where if there's an acute angle between the M1 and the M2, as in this case here, it can be incredibly challenging to make your microcatheter and microwire make that sharp turn, because the vectors are taking you into the dome of the aneurysm and doesn't want you to make that sharp turn, which you would need to do to place a stent, for example, in order to protect the neck before coil embolizing it. And the other is with stents, of course, you need the dual antiplatelet, same with flow diverting stents. And the results overall have been somewhat disappointing. If you look at some of the data out there, this endovascular meta-analysis for MCA aneurysms, looking at 12 studies, in about 20% of cases, they use stents, basically in addition to coils. And the occlusion rate was reasonable, about 82% complete or near complete. This is sort of in keeping with most modern data, but there was a rebleed rate of about 1.1%, which is significant, and then the recurrence rates are higher, of course, with endovascular treatments because of the failure of the devices. And so overall, you're looking at sort of morbidity mortality rates for ruptured about 6%, unruptured 5%. It's not trivial. Furthermore, the Clarity study was, okay, you seeing my slides again?
Yes.
Great, sorry for that. So the Clarity was a prospective European trial for endovascular treatment of all types of aneurysms, but they did an Emcee aneurysm subgroup analysis, and there was a higher rate of intraoperative rupture, about 8.5%, versus 3.7% for other locations, which was not quite statistically significant, but notable. A higher rate of thromboembolic events in the MCA location as well, and statistically higher mortality from thromboembolic events overall. So that's where, sort of these newer technologies of endovascular treatments have come into play and really continue to change the paradigm of how we approach treatments on an individualized basis. And that's things like next generation stents. They're not so next gen anymore, but they're stents that we're now able to be passed through very small microcatheters. The sort of the workhorse small microcatheters that we use for coils can now place these intracranial stents. They're not flow diverting, they're just sort of scaffold stents that hold coils into wide neck aneurysms better, but are more navigable because you can place them through these small catheters, which used to not be the case. And then flow diverting stents, I think people are familiar with these braided mesh tubes that help divert flow away from the aneurysm over time and causes the aneurysm to thrombose and disappear, and has been a dramatic game changer for ICA aneurysms, for example. And then finally, and sort of the purpose of today's talk is more of a focus on intrasaccular devices, which are these mesh cages, if you will, that that can be deployed through microcatheters into these shapes and placed inside the lumen of the aneurysm without having to leave anything behind in the normal vessel. Hence, some advantages with that. So again, it's not that we can't treat MCA aneurysms with stent and coiling. This is an older case of mine where I actually did employ a stent coil construct because the anatomy was fairly ideal for it. You can place a stent and really protect both M2 branches coming out of the neck of the aneurysm, and then coil the rest. And the angles are pretty not acute and easy to get through and so forth. So you can see the stent markers are these little dots, proximal and distal, and the coils are going into the aneurysm. And at the end, you have something that looks like this. And long term, intermediate term, you can get a really good result. And this patient never recurred and did well. So it's not that you can't do it. It can be done safely and reasonably. It's just a matter of selection. This is sort of the next generation stent technology that was utilized. And, the data, again, you're talking about in the mid 80s kind of occlusion rates, either complete or near complete, what's considered acceptable. But you do have to accept, again, that higher rate of thromboembolic strokes, embolic events, and then a non-trivial amount of in-stent thrombosis formation, and some technical complications with incompletely open stents. Other studies looking at this technology have shown, again, that there can be a relatively notable complication rate, 15% in this particular small retrospective study using Y stent constructs. That's when you have to go out each branch of the MCA with, for example, with stents, and that portends to a higher rate of complications because it's more metal, because there's some more turbulent flow created and so on. So again, these stents are advantageous because you can resheath them. They're smaller diameter. They can make those turns that might have been more difficult in the previous technology. But again, it's really the technical thromboembolic event rates that are making it somewhat limited. It's for the ideal anatomy more than a game changer for all aneurysms. And then flow diverters, of course, have gotten a lot of study over the last 10 years that it's been around in the United States. And if you look at this particular study on MCA aneurysms with flow diverters, again, this is a very skilled endovascular group out of Turkey, where they really are flag holders for advancing technology, and they push the envelope. And they saw a relatively good complete occlusion rate, 84%, which for endovascular technique is very much in par with what's out there. But you do have to jail one of the branches, in order to put a flow diverting out one branch. And that can lead to potential long-term problems down the road. And certainly there's a higher chance of embolic events with more metal related to the stent itself. So if you look at another study, they saw that with flow diverters at bifurcations, in general, you're going to see a high rate of MRI ischemic complications, many of which are clinically silent, but just proves the point that there are definitely emboli that are created, and a higher rate of procedure-related morbidity in this particular older study. So again, it's not that it can't be used for treatment. It certainly has its value and its role. This is the case of mine from about 6 or 7 years ago, where there's this complex M1 aneurysm, which is very difficult to treat. And she was initially ruptured, treated at an outside hospital in Louisiana, had partial coiling done, and then came back to Seattle, where she was from, and saw me, and she had recurred significantly. You can see the coil compaction of the initial coil mass and dramatic change in the morphology of the aneurysm. What we did is we decided to use the flow diverter and more coils to supplement the construct. And you can see at 8 months, there's a pretty good result there. It's not completely normal, but you can see luminal reconstruction, thrombosis of the aneurysm in general. And longer term, she's done really well, but not without her issues. She definitely suffered a lacunar infarct. You can see in the basal ganglia related to a perforator occlusion from the flow diverter itself. And furthermore, there are one-off cases like this one, which is a patient who was undergoing GBM re-resection for recurrence at an outside hospital, and the surgeon encountered, quote unquote, a lot of bleeding. He just sort of packed it off. It stopped, and he closed, and then several weeks later decided to get an MRI to follow up, and found this pseudoaneurysm, likely related to a MCA branch injury. And you can see this is the angiogram that correlates with that finding. And you can, again, do your flow diverting stent and coils as sort of a one-off treatment of this in a way that is very effective. And the patient went on with good long-term control. So what of flow diversion and MCA aneurysms in general? Well, as a community, I think it really hasn't supplanted the standard of care of clipping and even stent coiling. It really is for the occasional one-off case that's just ideal for it. Kind of like the ones that I showed, and out of the Gainesville group, Brian Ho still advises a clip first approach for these bifurcation or saccular aneurysms, although endovascular can have suitable indications depending on the situation. And then Pascal Jabor's group and Jefferson, a very experienced flow diversion shop, really pointed out the drawbacks of flow diversion, including the long-term issues of jailing MCA branches, the risk of perforator injury and occlusion, and so on. So still tempering the use of this particular technology in MCA aneurysms. And so most recently, because it has been recently FDA approved in the United States about a year ago, is the rise of what are called intrasaccular flow disruptors. These are those cage-like devices that can be placed inside the lumen of the aneurysm through microcatheters, as described. And they're a self-expanding mesh placed entirely within the aneurysm sac. Nothing stays in the normal arteries. There is a disruption of flow through the aneurysm neck, sort of that cage traps the blood and the fluid of the blood in the cage and causes stasis. It's sort of capillary action that keeps it in there without permitting persistent flow. And eventually, just like stents, it sort of heals over at the neck with neoendothelialization and scar tissue and so forth. The key is that it obviates the need for antiplatelets because there's nothing in the parent vessel, so you don't need to anticoagulate like you do with stents. Here's a company video, and I just want to sort of give you a mind's eye of what that looks like here. So this is sort of the, boy, this is really easy. Anybody could do it kind of a video where it's the perfect shape and the perfect aneurysm, but you can see the catheter deploys the device. It has the detachment system, and that leads to thrombus, occlusion of the aneurysm and persistence of flow there. Eventually there's neoendothelialization and healing. So what are the ideal, what are called web parameters? Web is the brand name of the intrasaccular device made by Microvention. And really there are ideal characteristics for an aneurysm to be used with this device. It doesn't mean they're the only ones you can use them for, but it's just what we consider ideal. and that is a wide neck aneurysm, so neck usually greater than 3 to 4 millimeters, a dome diameter between 3 and 10 millimeters. So you can't use it for every size aneurysm on Earth, but you can, in that range, it's suitable based on the available device sizes. Also what's called, this is really important, is sort of this off-axis angulation is a minimal amount of it. And that's the angle at which the aneurysm protrudes relative to the parent artery feeding into it. So if you have an MCA aneurysm, for example, in this case, if it goes straight into the aneurysm, that's a really nice on-axis, straight shot. Whereas if there's angulation, it can be much more difficult to center and place the device. So we'll call that the ideal when we talk about it later. And there's also a Webb occlusion scale that's used to describe outcome after placement, and A, B, and C are considered okay, acceptable, and that's all the way up from complete occlusion to a bit of residual neck, and then D is not considered good, where you actually have some filling of the fundus and dome of the aneurysm around the device.
How do you stop the propagation of clot? So you're trying to clot off the aneurysm, and it's could be proud in the parent vessels. How do you stop it from continuing to clot off the MCA vessels? I'm sorry to interrupt. I'm just.
No, it's a good question. I think that's the key, is making sure that the device is purely within the sac of the aneurysm. You can imagine how sizing it just right becomes really mission critical. If you over or undersize it, then you're not going to get a good angiographic result. And then you're right, if it is in the parent vessel, you will propagate clot, and that's a real problem of the device. What that means is that you have to, flip this too. You have to make sure you have it perfectly placed in the lumen right at the neck. And if it's not, then you end up having to bail yourself out with a stent construct or balloons or something like that. So that can be a technical issue related to the usage of this thing for sure.
Thank you.
But if you put it in just right, surprisingly, it doesn't propagate thrombus outside of the aneurysm. So it's all about the technical success here. So yeah, if you look at a group of really good recent studies on the Webb device, occlusion rates, follow-up and retreatment rates, if this column is the key. You're going to be in the 80s, the mid 80% adequate occlusion. That's either complete or near complete, with really reasonable follow-up. But then there's the usual retreatment rates, sort of in the 5 to 10% range, and that's really in keeping with a lot of the other endovascular tools that we have. It's not a dramatic improvement, but it does, again, have the advantage of not needing the antiplatelets, of treating aneurysms that might be otherwise very difficult technically to treat with stents because of the tortuous anatomy and so forth that we discussed. But it gives you a sense of where it falls in terms of the occlusion and retreatment rates. Just so you know, there is this unusual phenomenon of the device that people are still figuring out and wrapping their heads around, which is there's this 30% height loss over time that are seen in a number of these treated aneurysms and follow-up. So you can see that this was initially a very well-treated aneurysm with complete occlusion, but over the follow-up period, you can see there's this recurrence of the aneurysm in this area here that's sort of bowing into the device. It's like pushing up on it, almost like something's compressing it. And it's not clear what that represents, but it's thought to be some sort of a scar tissue formation within the device itself that pulls the device up and allows it to reform the aneurysm. It could simply just be recurrence from water hammer effect and so forth too, that affects the device because it's not, perfectly rigid, just like coils can be compacted and so forth. But you can see it leads to this phenomenon that's very common in this treatment group. And the argument is that these are clinically insignificant, even though they don't look good. And again, there's not enough data to know that for sure, but it certainly is a feasible argument. We'll see, just like we see 2 millimeter residuals after coiling. And, we used to get up in arms about how that's terrible and it's all going to recur and be a problem, and they just don't. as long as they stay at that size, so follow-up being the key. But we'll see what this turns out to be in the long run, and whether it becomes a liability or This is a case from Raj just recently, so I just wanted to show it's a really great technical result, but it shows another issue that's common with this device, specific to the device itself. So this was an old lady. Imagine, if you will, a ruptured basilar tip aneurysm. And this is a case where Raj did a really great job putting it at an off angle. You can see how it's not perfectly on axis, and he kind of had to self-center the device by pushing and pulling it into that angulation, and it was perfectly placed. But you still see after the placement persistent and sluggish filling of the dome. You can see the marker of the device in the aneurysm there, so it's in there, but yet you're still seeing that persistence of flow, and that's a very common phenomenon. In fact, only about 10 to 20% of cases after placement do you see occlusion of the aneurysm. So in the vast majority of cases, there's always a little bit of flow or within the sac of the aneurysm afterwards, which for ruptured aneurysms is a little bit hair raising. For an endovascular surgeon, you like to see complete occlusion after treating a ruptured, but you're just not going to get that with this. The good news is that in the large series that have been published, several of them, none of them reported a post-operative rupture in the short term, like an acute or in the long term. There's never been a reported case of a recurrent rupture, but there has been one case report recently by the guys at Pitt that had a case where a day or so after treatment of a ruptured aneurysm, they had a rupture event that required retreatment. So it's not impossible for that to happen, but obviously rare. So what does the data look like? This is an older study that came out of European trials, with MCA aneurysms, again, the usual 85, the usual web treatment here. These are the indications. This has to be the right size and shape and so forth. You're going to look at sort of a 6 to 10% complication rate, occlusion rates in the mid 80s. The webcast trial was a prospective European trial for the web of all aneurysms, but 57% of them were MCA, and they found an 18% thromboembolic event rate. One had a permanent deficit, so most of them were not clinically persistent, but still it's a relatively high rate. No intraoperative ruptures, which speaks to the technical excellence of the groups placing this. And then 8% of patients still also required other treatments. To kind of Rich's question earlier, is like, well, if you get into trouble with placement or it doesn't quite do the job, then you might have to use adjunctive treatments at the same time. There were technical problems as well because again, but I think that was learning curve stuff with a new technology that's probably going to get only better and better over time. Again, you see sort of the mid 80s in terms of the long-term follow-up, complete or near complete occlusion rates. So there are a number of studies looking at complication rates, and rather than go through them, really the summary is that there's a 10 to 14% thromboembolic event overall, and these are more modern studies as well, where the learning curve has been, sort of figured out a lot more. There's also that 3 to 5% morbidity. That's permanent, and then a less than 1% mortality. Again, from an endovascular standpoint, all within keeping with what is out there in terms of technology with next generation stents and flow diverters, but not vastly superior to that. So some points to consider with the web device: you need to use a larger microcatheter for the larger aneurysms, which can be technically more difficult and challenging. There is a deployment failure rate that's low, but it does occur, and that includes needing adjunctive treatments, as we just talked about. The aneurysms are rarely occluded immediately post-op. Again, we talked about that. And the huge advantage, of course, is that you don't need antiplatelet medications, but most, if not all, people who use the device start the patients on aspirin and Plavix before the treatment, just in case they need a stent or something like that. And many centers continue them on aspirin or some single or dual antiplatelet regimen afterwards as well, but not nearly at the duration that you would require for stenting. And so there's some data just based on comparing prospective study to prospective study that the web device may be slightly safer than flow diverter treatments based on this webcast trial versus the PUFS trial for flow diverters. So what's the future of these intrasaccular devices? That will undoubtedly become easier to deploy smaller microcatheters for delivery of larger aneurysms. That's just the way of the world in our field. There, the larger aneurysms will become part of the treatment in algorithm as the devices get sized up appropriately, bigger than 10 millimeters, basically. And we do have, we will have, the learning curve, just like we did with flow diverters, where it was very challenging in the beginning to place those things. And now it's just like, it's a fellow's case now. It's no big deal. And I think web will get to that point quickly as well. I think our complication rates always will improve with more selective use and more experience, but there's definitely some challenges with this device specifically with thromboembolic events like Rich alluded to. And the direct comparison to clipping in a clinical trial is needed, but it's never going to happen. You're never going to see a clinical trial with surgery versus endovascular. It just doesn't make a lot of sense to do that, and with the rarity of the disease and so forth. And then finally, the long-term data is obviously absent, and you can never really trust anything coming out of Europe in terms of follow-up. And so that's all going to come from the US centers, and it's just starting in the last 2 years. So we're going to get there. Well, where does this leave MCA aneurysm clipping? Of course, it's considered, these aneurysms are considered favorable for clipping due to the surgical accessibility. It's superficial, easily exposed, and the anatomy can be very easily controlled. It's useful in cases that are more difficult for stent coiling based on the anatomy we talked about, the dysmorphic shape, the broad neck. The durability, of course, is a really key factor in younger patients and patients unwilling to accept treatment failures. This is sort of an example of a large, broad-based aneurysm. This would be too large to treat with a web, but it gives you a sense of the versatility of clipping, where you can take a very broad-necked aneurysm like this, and you can clip reconstruct it however you wish to preserve the M2 branches and completely exclude the aneurysm. And this patient, I've known this patient for over, I think, 13 or 14 years, and she's done incredibly well with no recurrences over the years. Similarly, you can take a broad-based distal MCA aneurysm that, again, would be very challenging to treat endovascularly due to the bifurcated vessels coming out of the aneurysm itself. And you can use all your neurosurgical tricks and techniques. In this case, we can trap the aneurysm and prepare for a bypass with an STA end to end to preserve the M2 branch. You just check your flow, make sure your bypass is working with ICG, and then you can use your clips, reconstruct one branch, and the bypass fills the other. And you've got your complete occlusion there with preservation of flow distal to the aneurysm. So, we've all read the papers over the years, and there's no doubt that this can be done with low neurological risk and high rates of cure. Large series coming out of UCSF with Mike Lawton at the time, Eric Nussbaum, the Barrow group with the Bratt trial, and so forth. They've all shown, that in experienced hands, you can have extremely low complication rates, virtually almost no retreatment rates, and no recurrences. And this is pretty consistent across a lot of high volume centers. And there's even justification for the clip first strategy. This is from Buffalo, which is considered the mecca for endovascular, and they demonstrated that in their hands, based on their experience with about 22% of their cases treated endovascularly, that a clip first approach made much more sense because of the high rates of complications in the endovascular group with intraoperative ruptures and late rebleeds following endovascular treatment at an unacceptably high rate. So there also been very recently some studies comparing clipping and web directly. This is a German study where they looked at their own institutional outcomes from web versus clipping internally. Not surprisingly, there was a slightly lower technical success with the web versus clipping, slightly lower occlusion rates with web versus clipping, but relatively comparable treatment-related morbidity with both techniques. Perhaps slightly different complications, where with web it was more ICH related, and in clipping it was a mixture of things. And then, of course, not surprisingly, retreatment rates higher with the web. Another German group came out with a web-eligible aneurysm evaluation, where they looked at not just MCA, although those were 75% of the study, but all aneurysms that were considered "quote unquote" web eligible. And again, that's based on the broad neck, the size range of 3 to 10 millimeters, relatively on axis or angulation, and so forth. And they found, not surprisingly, because I think this was an incredibly biased group here, a very low rate of complications and so forth. And they concluded that we were not able to show superiority of web in terms of procedural morbidity in comparison to microsurgical clipping. But the point is well taken. And I think we wanted to look at our own data as well to evaluate that. And so we retrospectively identified in our own experience patients with 3 to 10 millimeter unruptured MCA bifurcation aneurysms that meet this sort of ideal web treatment paradigm. And this was all patients treated at Harborview. It was a retrospective analysis. The total number of MCA aneurysms was 257 over that period. Again, about 2/3 unruptured, 1/3 ruptured. And these were based on cases that were selected by dual trained neurosurgeons with both endovascular and open surgical options presented to the patient. So it was selection bias, but at least it was selection bias based on providers with endovascular expertise. And if you look at our cohort, the median age was 60, but the range was 20 to 83, and greater than 60% of the cohort were older than 60. So not a young, it wasn't like biased towards only young, healthy patients by any means. 67 patients with 69 unruptured MCA bifurcation aneurysms that qualified as web eligible based on size, morphology, and orientation. And, similar to what we've been talking about, very high occlusion rates, both short and long term, and no retreatments. In terms of complications, it was 4.4%, but they were, none of which were led to any neurological morbidity. There was an asymptomatic subarachnoid hemorrhage, subdural hygroma post-op that did not require retreatment, and a wound infection. And so, again, just proving the point that this can be done with low morbidity, no mortality, and low, if not zero, neurological morbidity when selected properly. And so in terms of the discussion, this is, of course, a highly selected population. We don't just operate on everybody. And so there is some bias, but, when you look at my overall cohort, there's still, 85, 86% of my patients are probably going to get clip recommended to them. And it is also problematic to compare a novel endovascular technology that's been around for a couple of years in the United States, still rolling out, frankly, and a well-established neurosurgical technique that's been around for several decades and we've been perfecting over the many, many years. So it's not a completely fair comparison, but it is important to note that. And then in terms of our study, it was an older cohort, and it's compelling to say that there's no complications that occurred in any patient greater than 60. So, you can state the selection bias, but at least we're, choosing appropriately, I think. And then finally, for ideal web eligible aneurysm, the complication and long-term occlusion rates are really, this is just sort of it's important to have a benchmark for comparison as intrasaccular devices begin to proliferate in the US, be able to educate our patients who are looking for the right choice, what are the real numbers in terms of efficacy and safety. So yeah, if we kind of like summarize, this is a bit busy slide, but if you summarize the clip, the web, the stent coiling, and the flow diverter data out there in terms of occlusion rates, retreatment rates, morbidity, mortality, you're going to see that, not surprisingly, clip does much better in terms of occlusion and retreatment rates, and fares fairly similarly with web and stent coiling with treatment morbidity and mortality. But really, the discussion and the community in endovascular isn't really focused on that. It's really focused on how does web compare to existing endovascular technology, and the answer is that it compares favorably, and because of that, it will continue to gain acceptance and broader usage. So is endovascular treatment of Emcee aneurysms considered non-inferior to clipping? And in order to talk about that, I just want to take you down memory lane a little bit here in endovascular, which is, if you remember flow diverting stents, they were designed to treat ICA aneurysms. And back, if you can remember the days before flow diverters, ICA aneurysms were treated with clipping. And it turns out that even in the best of hands, in the best of centers, just like the ones that are talking about how Emcee aneurysms are so safely treated and everything, the complication rates were always at least 10%. Ophthalmics, paraclinoids, you name it. And there was just never a way to get below that number. And yet with flow diverting stents, that's reduced dramatically. The rate's probably more like 3% now. And so, flow diverting stents has become the standard of care because it actually has reduced morbidity. It is a significantly better tool for the problem that it is dealing with compared to the alternative. Similarly, when we look at the carotid endart versus stenting studies like CREST and so forth, we see that we continue to use carotid endarterectomy as first-line treatment. Mike is sort of our go-to carotid surgeon, and he operates on people as the first choice unless there's a compelling, qualifying reason why they should be stented instead. And again, we don't stent patients. Endovascular kind of lost out on this one because of the data. Prospective randomized controlled data. So what about intrasaccular flow diverters? Well, right now, this device has neither the efficacy better than surgery nor morbidity improvement compared to surgery. Yet it's still a matter of discussion whether this should become part of the standard of care, which is somewhat befuddling because the data really continue to support a clip first approach in properly selected patients. My own data will tell me that, and the data in the literature confirms it. But web and intrasaccular devices are here to stay. And why is that? And again, it's because these devices are being compared not to clipping, but to existing endovascular treatments. There is no doubt an endovascular treatment inertia. It's generated first of all, by the incredibly large pool of available NIR providers in the United States. About 200 new interventionalists, neurointerventionalists graduate from centers across the US every year. And they're incredibly diluting the number of neurosurgeons that could potentially offer surgical treatments. So you're more likely to see an interventionalist only than a dual trained neurosurgeon if you have an aneurysm. Not facetiously, but there is definitely an industry push marketing going on with intrasaccular devices, which no question can drive behavior. The ideal Emcee aneurysms for intrasaccular devices do exist, those straight in, perfect chip shot, web device cases, and those will be great. Those will be really fantastic for our patients because it will really offer a minimally invasive, low risk treatment. I think it's the off axis or the ones with non-ideal sizes and shapes that will be more at risk for complications and thromboembolic events and technical issues and so forth. But for those ideal slam dunk web cases, it's going to be great to have those, and that's going to be another reason why this device will continue to proliferate. And then finally, eroding volumes have feed-forward implications on the training of next generation cerebrovascular microsurgeons. That's our residents and our fellows, and I think that we're sort of at a crossroads in terms of volumes and training. Where are we really going to have a cadre of experienced enough microsurgeons to feel comfortable continuing a clip first approach? And I don't think there's a clear answer yet to that, because centers of excellence like UW will continue to create those microsurgeons, but not every center will. So we'll see if that's going to be enough. So are intrasaccular devices changing the practice patterns? The answer is yes, but while results are promising, it's of course never a panacea. It never is, even though we always wish it was. And it's just another iteration, the evolution of endovascular neurosurgery, which will find its key role where it does its best. So in terms of the treatment paradigm, again, continue to use all the tools available and apply them logically. seek out the lowest complexity treatment. The existing literature is merely a guide. It's not your data, it's somebody else's data. And so take it with a grain of salt and be honest with your own outcomes. Play to your own strengths, and remember not which to use, but when to use the tools that you have in front of you. So in conclusion, the data suggests that in a selected population of patients, clipping for web-eligible unruptured MCA bifurcation aneurysms is the optimal first-line treatment. And prior endovascular solutions are considered non-ideal, suitable, or satisfactory for MCA bifurcation aneurysms because of the factors that we mentioned in terms of anatomy and so forth. But intrasaccular devices clearly are changing the paradigm. And despite the clear benefits in safety and efficacy with clipping, I think the inertia of CNS endovascular surgery will lead to the web becoming part of the standard of care. It'll just be part of the toolbox that we use, and we will probably just continue to perfect the technology for this purpose till it gets to its asymptote, and we find where it's really best suited. And finally, and most importantly, I think for our residents, is that microsurgical training in aneurysm surgery remains as important as ever. And my soapbox speech on that is, as I've told some of you already, is that you will be differentiated in your value to a department and a cerebrovascular center by your microsurgical training, because the endovascular training will be commoditized and everyone will have that well in hand, but not everyone will have the microsurgical part. So continue to focus on that as the differentiating factor in your careers.